Morning, everybody. Thanks for being here. It's my distinct pleasure to introduce Dr. Friedman. Dr. Ellen Bogan asked me to talk or to introduce his talk because he says I've known him for years, which I suppose is technically accurate. He grew up in Skokie, Illinois, which is a town near and dear to my heart. Went on from there to Pomona College, and then I think has been in Boston since. I might have skipped something. Um, but I met him at a stereotactic and functional course down in Oregon. He came up and introduced himself and said he was interested in spending some time here with Ben and me. And uh, what was interesting is that he has worked with um, one Ziv Williams and then Hugh Hare. And one of the things he's been working on was you can imagine between those two is kind of decoding brain signals and then work on prosthetics. And I know a lot of folks who go into functional and come to the University of Washington kind of want to build a mind control robot, and he's actually worked on the arm parts of this. We work on a lot of BCI here, so the mind control part we do spend time on, but the actual limb control is kind of this the secondary thought, and I think Gabe's going to have some interesting things to tell us about that today. So, without further ado, Dr. Friedman, thank you for being here, both as uh, both to give us a talk and to as my fellow. So, thanks.
Thank you very much.
Thanks, Drew.
Thanks, Dr. Cohen. Thanks, Dr. Ellen Bogan. Really excited to talk to everybody today, as Dr. Cohen was mentioning about the work they've done both on central and peripheral interfaces for restoration of neural function. Just to get started, I have no conflicts of interest to disclose. And as an overview for my talk, I'll go into my background and motivation for this type of work. I'll talk about central approaches, both for motor decoding and also stimulation, and then peripheral approaches for restoring proprioception function. Talk a little bit about the work I've done with device development and translating that into the clinical applications, and then I'll close with my vision for advancing an integrated functional neurosurgery program. As Dr. Coe mentioned, spent quite a bit of time now in Boston for the last 12 years. Before that, I was out on the West Coast at Pomona College in Southern California. Now excited to be here as your functional neurosurgery fellow. Having a good time so far. I'm also joined here by my wife, who's a first-year infectious disease fellow at the University of Washington, and she's happy to help if you need any assistance with shunt clearance or hardware infections. My two kids, Levi and Noah, and then my wife's grandmother, who lives with us as well. So my motivation for this type of work, like many people, is drawn to neurosurgery by a single patient episode. In this case, this was a 42-year-old healthy male. He was brought into the emergency room by ambulance after a motor vehicle versus unhelmeted bicycle collision. CT head showed diffuse multi-compartmental hemorrhage. He was taken for emergent right hemicranie with ICP monitor replacement. And this was followed up on post-op day 3 with the ATL due to intractable ICP crisis. This is a patient that we see quite commonly, especially here at Harborview. But in this case, this wasn't someone I saw in the ED as a junior resident or operated on as a senior chief, but this was actually in 2002, and this was my own father. And if you'll bear with me just for a minute, I have a brief video with a lead-in by Dr. Oz recounting this episode in my life.
In the next story, our father is just beginning on the long road back from near death.
We're only going to do one per row, and I'm going to ask you a question, okay?
We were out for a family bike ride.
Please stretch out your hand for a little bit.
Sure. And I went through a stop sign very close to our house, about a block away, and I got hit by a car. I know very little else about what happened to me. So I was in intensive care for about 5 weeks.
Mr. Friedman came as close to death as you could possibly come without actually dying. There are two people that for sure saved his life. One was the neurosurgeon that operated on him, and the surgery was very, very complicated. The other person was his mother. His mother had to say yes to the neurosurgeon, for the neurosurgeon to take out part of Mr. Friedman's brain in order to save his life. He is one of those people that do not match the textbooks, which means that we need to go back and do research and rewrite the textbooks.
3 months later, Rick's progress allows him to manage old routines by himself. It has also added more quality to Rick's and his family's lives, especially when it comes to getting around. Although grateful for his improvements, Rick remains focused on what lies ahead. To up the odds for a full recovery, Rick still wagers 150% effort each day.
So as you can see, as the 12-year-old in the video at this time, I was both impressed by the amount of recovery that my dad made from his injury, but even with the best medical care, best surgeons, and the best rehabilitation available in the country, he still remained hemiplegic in his left arm and left leg, which was his dominant side. And so he had to relearn how to do all activities of daily living. And for me, it was surprising at the time that we hadn't worked out this issue of motor paralysis. And it got me interested in neurosurgical approaches to potentially repairing this condition. So over the coming years, as I saw the advances being made in early neural prosthetics, I got interested in this problem, which affects about 5.4 million people in the US. We see a lot of this both from traumatic brain injury, spinal cord, and stroke. And there's numerous medical complications as well as complications on quality of life, leading to depression and other things. And right now, there's limited existing treatments. One treatment that I had the opportunity to work on during residency with one of my mentors, Dr. Justin Brown, was nerve transfers in the setting of tetraplegia from spinal cord injury. So in this case, this is from a chapter that we put together. This is a brachialis to anterior interosseous nerve transfer for restoration of pinch function and finger flexion. This is the technique that we use for our nerve anastomosis using 9/0 nylon suture as well as an Axoguard tube to help preserve the coaptation site. And this is an example of the results that you can get from this type of transfer. That being said, this is a relatively limited subset of the overall number of patients who experience motor paralysis. And so that speaks to a need to broaden our approach. And that's the rest of the work that I have been embarking on, as Dr. Koh alluded to. So for any type of neuroprosthetic system, there's essentially 4 key components. The first is we need to be able to record neural activity, typically from the cortex, but could be from other places. We have to be able to decode that neural function into intended action. Then the part that's gotten less attention is we actually have to estimate the stimulation parameters needed to evoke such action, and then finally deliver these impulses in order to produce that motion. So there's a couple main methods that have been used historically for these BCI systems. The first is microelectrode arrays, most commonly the Utah array. The advantage of such an approach is that it gives you very high signal fidelity. The disadvantage is that it's extremely invasive, as I'll show you. There's biocompatibility limitations in the form of immune reactions, and you're recording from a very small field of the overall cortex. Another modality that's commonly used is EEG, which allows you to record from the entire cortical field, but has relatively low signal fidelity, and it's not as easy to put on and take off every day. So in terms of microelectrode arrays, I had the opportunity during residency to work with one of my mentors, Dr. Williams. This was a brain gate implantation procedure at MGH, where we put in 6 arrays that we had 2 arrays connected to 1 post, and we put in a total of 3 posts. over motor and speech areas. Here's an example of the pneumatic inserter that we use to actually press the microelectrode array into the cortex so it's recording appropriately from those layers. For the vascular folks in the audience, this is widely considered to be the most sophisticated method known for inducing subarachnoid hemorrhage. Another approach that I didn't mention up there that's more modern and much more familiar to all the folks here is using ECOG. So this was a project that I worked on during my HHMI year with Dr. Williams and also Dr. Koka Hu, where we used a 32 contact ECOG array over the ventral premotor area in order to decode intended motor movements. So this was implanted in a rhesus macaque. Each recording session, the animal performed 80 trials of reach return movements, which were pseudo-randomized to right and left locations. And the monkey used the side contralateral to where the ECOG array was implanted. What we found was prior to movement, we saw a very significant decrease in intermediate frequency power in the beta range that happened prior to movement onset. And then once movement onset occurred, we saw an increase in activity in the gamma range that continued through the reach movement and also through the return movement. When we looked at this using a time series analysis, we found that this deflection in the intermediate activity occurred significantly before the increase that we saw in the high frequency activity. And this was regardless of whether the animal was reaching to the left side or the right side, suggesting that this could be used as a biomarker for decoding timing of movement during reach return actions. This work is also being done now, as you heard about a couple of weeks ago, with Dr. Ogeman, Dr. Heron, Dr. Cohen, Dr. Grannon, where we're now looking at activity-dependent cortical stimulation. And the idea here is that in patients who have experienced stroke and have chronic motor difficulty, we're now going to stimulate at one site and measure corticocortical evoked potentials at another site. And then we'll be able to provide stimulation at the depolarizing phase of beta activity with the hope of maximally producing improvements across the damaged corticospinal tract. We're doing this using the Cortec brain interchange device, which Dr. Cohen and Dr. Grannon implanted in July. And I had the honor of presenting this work at the Adaptive Neuromodulation Workshop last week at the Mayo Clinic, along with some familiar faces there. This was some photos from the intraoperative implantation. This is the receiver that's used to record the signals. And then this is some data put together by Han Bin Cho demonstrating that we have stability of these signals with the standard 1/f spectral pattern that continues both from the intraoperative signals to what was day 2 of testing. And now we're undergoing movement threshold trials to assess exactly how much stimulation we can deliver without producing unwanted effects such as seizure. So I had the opportunity of participating in that last week, and then we'll continue that tomorrow and Friday as well. So this year we'll be focused on establishing the safety of this device. The patient will receive 6 weeks of open loop stimulation testing, followed by a 24-week monitoring period. And at the conclusion of that, the patient will receive 2 weeks of this closed loop beta depolarizing activity. And that will be followed by device explantation. In future years, the closed loop portion will be moved up front, followed by 24 weeks of monitoring and then explantation. Another closed loop simulation project I'm working on is with Dr. Ko, where we're looking at adaptive DBS or deep brain stimulation, which has the promise of actually modulating the degree of stimulation that's provided based on either physiologic signals or decoded behavioral activity. So in this case, we're also looking at beta band power, which is thought to be a biomarker for symptom severity in Parkinson's disease. So these are recordings taken from one patient's DBS system, where you can see this peak, especially at contact 0. And what the adaptive DBS system does is it uses the recorded LFPs and then modulates the stimulation settings accordingly. So this is data from another patient where you can see that over time, as the measured LFP signals stay within this adaptive zone, the amount of stimulation can be reduced, which allows for more targeted stimulation control. So next steps will be correlating that with clinical symptom severity and then assessing whether we see changes in the adaptation that correlate with improvement in the patient's symptoms. So the meat of the talk that I want to get into is actually the second component that Dr. Ko is mentioning, which is actually once we have these signals from the cortex, how do we actually do something with that other than, for example, controlling an iPhone or a computer screen? So to do this, I turned to the MIT Media Lab across the river from MGH, which is a research enterprise dedicated to exploring the future of human adaptability, human-computer interaction, prosthetics, and other motifs related to technology, science, and design. And here I joined the lab of Hugh Hare, himself a double amputee from a climbing accident many decades ago. And what I specifically worked on was called the agonist-antagonist myoneural interface. So this was invented by Hugh Hare, as well as a plastic surgeon at Brigham and Women's, Matt Carty. The first implantation occurred in 2016, and now almost 30 patients have received this surgery. And the basic idea is that during a standard amputation, no care is taken to actually restoring the native architecture of the limb. And so you have these agonist and antagonist muscles that are essentially just floating in someone's residual limb, and you no longer have the interplay between them that's responsible for so much proprioception. So during this surgery, rather than just doing a traditional amputation, a coaptation is performed between opposing muscle groups. So, for example, the tibialis anterior and the lateral gastrocnemius muscle are coapted, as well as the peroneus longus and tibialis anterior. So what that means is that when a patient produces volitional efferent contraction of their tibialis anterior muscle, which is commonly done for dorsiflexion, they experience an afferent stretch on their lateral gastrocnemius, which I'll show you in a few slides. And alternatively, when the patient wants to plantar flex and they perform efferent contraction of their lateral gastrocnemius, they experience a stretch on their tibialis anterior muscle. What that means is that in normal architecture of proprioception, which is essential for joint stability, trajectory planning, as well as fine motor control, you're able to restore some of this muscle force signaling, which normally takes place in Golgi tendon organs at the joint site. And those signals pass through type 1B afferent sensory fibers back to the spinal cord into the sensory cortex. You can imagine that proprioception is very important in prosthetics where the patients, other than looking at the device, otherwise have no idea where exactly in space it is. And so if we can give some of that proprioception back by restoring this native architecture, the thought is that it'll be easier to use these next generation devices. So I designed the study comparing 7 patients who'd received the AMI construct to 7 control patients who received standard amputation. And I found these control patients through a bioinformatics protocol I developed that allowed us to perform medical record search across the whole Mass General Brigham patient chart and then reach out to these patients to see if they're interested in participating. And all this work was supported by grants from the R25 and NREF programs. So in this study, I designed 3 components. The first was volitional control. That is, the patients who receive the AMI construct, are they better able to generate discrete muscle movements compared to control patients? The second is when we apply functional electrical stimulation to a residual limb of these patients, do the AMI patients have a more coherent or more consistent interpretation of these signals compared to control patients? And finally, could we use closed loop functional electrical stimulation to actually level the playing field and see if patients who have the control patient are now able to have similar levels of proprioception function? So the first component of this study, I looked at measuring muscle strain in these patients as a proxy for the degree to which they're able to generate specific muscle movements. And to do this, I placed an ultrasound probe on the flexor muscle while recording surface EMG signals from the extensor muscle. And here's an example of what that ultrasound activity looks like. You can see a shortening of the muscles during this flexion activity. We could also measure the EMG activity of the extensor muscle as a proxy for the degree to which it's moving during this contraction. So what I found was that patients with the AMI construct had much more discrete or precise movements compared to patients in the control cohort, where there's much more grouping or bunching of the muscle strain during these activities. And we saw a similar pattern in the EMG activity, suggesting that patients who have the AMI construct have a better sense of how much exactly the muscles in their residual limb are moving compared to control patients. Next, I want to explore a mechanistic reason for why that's possible. And so what I did was I designed a stimulation paradigm where I took 25 gauge fine wire electrodes that were inserted with needles into the muscle itself, and then generated an electrical current across these wires that produce muscle contraction. If you look closely to the stimulation being delivered here, number one, this is completely externally modulated. The patient is completely at rest, not doing anything to produce contraction of their muscle. And you can see the degree of contraction that you get from that stimulation. But what you'll also notice is that during that stimulation, because this is an AMI patient, you can actually see the pull on their lateral gastrocnemius muscle from that stimulation being delivered. And here you can also see stimulation being delivered to the lateral gastrocnemius muscle. Importantly, for these patients, the stimulation was not painful at all. And on the contrary, their experience of it was actually that their phantom limb was moving in correlation to how much stimulation was being delivered. So at the higher ranges, they felt that their phantom ankle was being, in this case, dorsiflexed all the way up. And in this case, with stimulation of the lateral gastrocnemius, they felt that their phantom ankle was being flexed all the way down. And so what we could do with that was that I applied a goniometer to their intact limb, and this is a device that essentially measures angle deflection, and I provided stimulation to the affected limb at varying levels to which the patient was blinded to. And I asked the patient to mirror exactly how much they felt like their muscle was moving in the affected limb during this stimulation. And so this enabled us to quantify the degree to which patients with both AMI construct and traditional amputation are able to perceive the stimulation and how much it correlates with the amount of stimulation that they're receiving. So during this task, what we found was that patients with the AMI construct had much more fine resolution of their perception of this movement. You can see much more graded patterns, whereas the patients with the traditional construct, they still could tell whether it was high or low, but they didn't have this degree of resolution, suggesting that the AMI construct might work better for a functional electrical stimulation paradigm because they have finer perception of the amount of stimulation that they're receiving. In a similar task, the patient was also blinded to the level of stimulation that they're delivering. But in this case, they're asked to counteract that movement. So, for example, for stimulation to the tibialis anterior, they were asked to perform essentially a phantom plantar inflection, try and resist that movement using their lateral gastrocnemius muscle. And then we asked them to quantify the degree of effort that was required to counteract based on the level of stimulation that was being delivered. And we saw much more clear correlations between perceived torque and the stimulation current for the AMI patients compared to the control patients. Finally, I want to see if we could use closed loop stimulation to level the playing field between the two groups. And I used this robotic prosthesis that was designed by a graduate student in the lab, Tony Hsu. And in this paradigm, what was taking place was that we recorded surface EMG signals from the patient's affected lateral gastrocnemius muscle. This was used to drive the torque of the robotic prosthesis, which was then pushed down on a pedal. Depending on how hard the pedal was pushed down on, that triggered stimulation from the digitimer stimulator, which then fed back into the tibialis anterior muscle. And this essentially mimicked the feedback that you would get. For example, if you slam down on the gas pedal, you get signals back going through the tibialis anterior that tell you how much pressure is being returned to your limb. And so we were trying to recapitulate that closed loop control. So what we found, so here you can see this is EMG intensity here, which correlates nicely with the amount of robotic torque based on varying levels of effort that the patients were instructed to produce. And what we saw, what we wanted to look at is in situations that are open loop, i.e. where stimulation was not being returned back into the tibialis anterior, we saw significant differences there between the amount of effort or the amount of torque generated by the robot compared to when it was being controlled by the intact limb. However, when we used the closed loop condition, we saw that these differences no longer existed. This was slightly better for the AMI patients compared to the control patients, but overall, this showed that both groups benefited from this closed loop stimulation paradigm. I also had the opportunity to contribute to other projects in the lab. So in this case, we were actually connecting the robotic device directly to the patient's limb. And what we found was that this produced, in the AMI patients, we saw improved walking speeds, improved neuromuscular gait dynamics, and improved obstacle avoidance. We also just put out in Science what's called our osseo-integrated mechanoneural prosthesis, where the EMG electrodes are implanted directly into the limb themselves rather than externally, and then tunneled out through a titanium rod that then connects to a neuroprosthetic device. I also want to highlight some work that's being done by other groups around the world and around the country. This is from the Gregoire Courtine group out in Switzerland, where they have actually used ECOG signals to trigger spinal cord stimulation. And some of this work was adapted in a study done by Chet Moritz here, where they used non-invasive spinal cord stimulation and saw improvements in upper extremity function in patients with spinal cord injury. They're now embarking on a phase 2 study with an implantable device as well. And then we're all familiar with the work being done by Neuralink as well as Centrode. And all of this highlights the need to translate these scientific findings into devices themselves so that we can translate them into the clinical setting. If I can take a slight detour here into some work that I've done on device development for a different condition, in this case, hydrocephalus. So this is a 21-year-old female patient who represented to MGH 6 months after receiving an ETV in the setting of congenital hydrocephalus. related to tetraglioma. In this case, when we went back to do a redo ETV, we went through the lateral ventricle. And then when we got into the third ventricle, what you can actually see is there's a tiny perforation that still existed from our initial ETV. The membrane was still so thin that we were able to pass the Fogarty balloon directly through without even using bipolar or anything else to open that. But it showed that, even though there was still a small amount of flow going through, it wasn't enough for the patient. And we had to come back and make another stoma in this case. And so I showed this video when I was TAing the neuroanatomy course at Harvard Medical School. And one of the students said to me, it's kind of crazy that you make the hole, but you don't do anything to keep it open. And so that got me interested in to start looking into potential solutions for this problem. And this is some data that we put together here. If you look at ETV, which typically has a failure rate of around 40% in the first 6 months, if you actually go into the literature and look at causes of that failure, closure of the stoma as opposed to other causes, for example, scarring below the membrane of the third ventricle or just inadequate flow across an adequate stoma, you can see that closure represents the vast majority of cases of failure. And so if you extrapolate a 30% or 40% total failure rate, you can see that about 30% of ETVs total fail because the stoma closes, which speaks to a need for some kind of solution to provide a more durable opening. And so I worked with this student, Bryce Starr. These were some initial prototypes that I came up with. First, I was thinking we could use some kind of balloon-assisted device, but gradually shifted into more stent-based design. And so essentially, in this idea, use a stent device down the same endoscope that you use to perform the ETV itself. You bring the catheter that holds the stent below the floor of the third ventricle and into the prepontine cistern. You release the distal portion of the device, then pull the catheter back and release the proximal portion of the device. We assembled a team that includes Ellen Roche, a professor of mechanical engineering at MIT, as well as a couple biotech advisors. And we received a $50,000 grant from the Deshpande Center at MIT, which helps commercialize these types of inventions that are created at MIT. And this funding was renewed for a second year. We submitted a provisional patent for our technology here. And this is what our prototype looks like now. This is an adult version of the device. And then we also have a pediatric version of the device. We entered into an agreement with Karl Storz where they actually provided us for free an entire neuroendoscopy setup that we've been using for testing currently in the ex vivo porcine model. And this is some video from our latest test in June where you can see here's the endoscope. We have the distal portion of our stent being advanced below the floor of the membrane. And then I've slowed it down a little bit here so you can see the device. We retract the endoscope slightly and then release the proximal portion of the device in order to hold the membrane in place. So we're now working on moving into chronic animal studies, and we're hoping to submit an IDE to the FDA probably around the third quarter of 2027. So all this put together, you can see that we're now entering what I call a new era of restorative neurotechnology. And there's many reasons that we've got into this phase now, especially with this technology rapidly advancing in the past 2 to 3 years. So reasons for that, we have next generation recording and implantation equipment. With the advent of machine learning and artificial intelligence, we have more advanced decoding algorithms. with the advances in the hardware technology, we have better stimulation techniques. We're able to build on the prior efforts of enterprises like BrainGate that have showed proof of principle, have enabled venture capital to provide billions of dollars of funding for this technology. Furthermore, with ubiquity of digital devices, patients are more willing to trial the technology, even if it means just being able to send text messages, send emails, or play first-person shooting games. But ideally, what we'll be able to do is move beyond providing just this digital freedom. And what in order to get there, what we need to do is prove the safety and reliability of these devices and develop better peripheral stimulation techniques that allow patients to actually generate a true naturalistic extremity function. And don't just take my word for this. I was actually a little pessimistic about the pace of development, even as early as a couple years ago. But now, this is from the Wall Street Journal back in May, they've showed that in the next year, the number of people with BCIs implanted is set to double. And this is an analysis performed by the investment bank Morgan Stanley, where what they found essentially, based on their analysis of the market, is that in the next 10 years, by 2035, they believe that in patients with ALS, stroke, and spinal cord injury, 15%, 10%, and 5% respectively of these patient populations will have received BCI implants. By 2045, those numbers go up to 50%, 30%, and 25%. And based on the tens of thousands of patients who have these conditions, that translates into either thousands of or tens of thousands of patients total for an applied market value in the hundreds of millions or even low billions of dollars. And so this, based on their analysis by 2045, they believe that just around 2 to 3% of total patients who are candidates for these devices will have received them, with sales of these implants reaching into the billions of dollars, with significant year-over-year growth. So putting that all together, my vision for functional neurosurgery is an integrated functional neurosurgical approach for restoration of movement function. What that means is for patients with cranial or spinal cord injuries, the goal would be to restore motor function through neuroprosthetic bypass devices that can record from the record from the cortex using either ECOG or microelectrode arrays that are paired with peripheral stimulation devices. And for patients with brachial plexus, peripheral nerve injuries, or amputation, then continuing to work on these direct prosthetic implants as well as nerve transfer techniques. My clinical goals within functional neurosurgery would be to build on the strength of the established epilepsy DBS programs, expand DBS use for emerging indications like psychiatric conditions or disorders of consciousness, bring in VNS for things like stroke, continue it for epilepsy, bring in focus ultrasound for movement disorders and other uses, for example, sonobiopsy, build on efforts of using neuromodulation for pain, and then continue things like peripheral nerve surgery, which Dr. Grannon has built up a lot here, as well as gamma knife surgery. I also plan to apply for a K award, and my specific aim is building on the work that I'm doing here with the Cortec device would be to actually not just see whether we're simply using the stimulation to improve motor function, but can we actually look at these ECOG signals themselves and use that to decode a dexterous upper extremity movement? For example, thumb pinch, wrist movements, and finger movements. I'd also like to establish a mechanistic basis for this decoding by using a stimulation-based perturbation strategy to figure out exactly what are the critical nodes for encoding this motor activity. And finally, in a different set of patients, I'd like to use closed loop stimulation to see whether we could use these decoded ECOG signals to actually drive intended movement and see whether this can be done more accurately compared to open loop stimulation itself. So going forward with my vision for functional neurosurgery, this would be clinical excellence for every patient, bring in extramural research funding from the NIH, NINDS, private foundations, as well as philanthropy. I'm using these cutting edge research to drive an expanded patient referral base, developing innovations that result in commercialized IP revenue, and finally establishing UW as the go-to clinical trial site for this BCI neurotechnology testing. As for my father, who I told you about at the beginning of this presentation, he had 23 long and happy years following his injury. He got to meet 4 of his grandchildren. And even though he's no longer with us, his story speaks to the millions of patients who'd be able to benefit from this type of technology. So I have a number of thank yous that I'd like to make to people here. Dr. Ellenbogen, thank you for making this fellowship possible. To Dr. Ojiman, thank you for your leadership of the UH3 study. Dr. Coe and Dr. Grannon, thank you for all the amazing education in the OR. To Dr. Coe, thank you for showing me the magic of subpial dissection and the Phelan table. To Ben, you've worn many hats over the years: senior resident, chief resident, landlord, fitness inspiration, and now associate fellowship director. But above all, over that time, a friend. I'd like to thank Dr. Ferreira and Dr. Kim, who were instrumental during the interview process for the fellowship. Also, Dr. Levitt, for all your help with getting the UH3 grant here for this fellowship time. Also like to thank all my collaborators, funding sources, as well as my wonderful family who's been so supportive over all the years. I'd be happy to take any questions. Thank you very much for your time.
Gabe, that was a great talk. Really exciting, exciting. Any questions? Wow. I think you silenced everybody. It was really quite inspiring, and starting out with your story about your family, which we did not know. So that is good motivation.
Rich, I have a question.
Dr. Ojiman. Yeah, we can hear you, Jeff.
Yeah, thank you. Well, thanks so much. Recruitment is tough, and I think you did lay out maybe it's more explicitly how do you get to say, yeah, I want to, like, especially the brain gate, I want to put this in my head, even though you can't really tell me what the benefit's going to be. And what's your approach to that?
I didn't fully hear the question, but my understanding is, how do you talk to a patient about convincing them to go through with this?
Yeah, just recruitment in general at this stage of the technology.
Yeah, definitely. I think that it's obviously a very fine balance, because you want to get people who are interested in taking part in their research, but obviously you don't want to overpromise, because the technology is still very much in its infancy. And so I think, number one, you have to be very honest about what these devices are currently capable of. Importantly, that currently it's investigational and not therapeutic. I think that patients often, even if you explain to them that it's investigational, they still have this hope that they may derive some benefit from it. And even though it's possible that they might, I think it's very important to be direct, because the last thing you want is mismatched expectations between what the patient experiences and what they hoped for. I think, fortunately, for this patient cohort, many of these patients, they truly have no other options, and they understand on a day-to-day basis how difficult their lives are. And for many of them, even just participating in the research itself is something for them to be excited by and to be engaged in, and it gives them something to do. And even though they know the realities of it, they often have an altruistic motivation, which is, even if it doesn't help me, it may help other people who are going through what I'm going through. And so it's really about finding the right patient who has that attitude rather than someone who's hoping that it will, suddenly make them walk again. Dr. Levitt?
Yeah, great talk. I had more of a kind of research related question. So as somebody who's gone through the previously R25 and is now in a second increment UE5, if you could just maybe comment a little bit to the residents who are going through it, how your aims and the arc of your project has changed from the time you wrote your first R25 proposal, probably as like a fourth year resident or something, to now, and maybe just comment a little bit about like what you thought it was going to be versus how it is now versus where you think it's going. Because I think a lot of people in the R4 position, when they write their grants, they're thinking, well, this is my plan and this is how it's going to work out. And I'm going to be here, 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 and here. And obviously science is not like that. So you want to just comment a little bit about your journey?
Yeah, absolutely. And that's a great question. So when I initially wrote my initial R25 application, I believe as a third year resident, at that time, it's before the dedicated research time. You haven't joined the lab. In many ways, you don't know exactly what's going on there, and you're kind of building off, oftentimes, a project that's already kind of being gotten off the ground. And you put that together, you submit it. I was fortunate enough to have that approved. But then once I joined the lab, unsurprisingly, that project was kind of being already worked on by a couple people. And I was helping out with that, but I quickly realized that if I continued with that, I was more in a technician role on that project, and I wasn't going to have the type of data ownership and oversight that I wanted to have. And so that's when I shifted into the other project I talked to you about today. And ultimately, that project had much more relevance for my overall goals, and it was very fortuitous. And, there was a little bit internally, I had a little bit of tension because it wasn't exactly what I had written for the R25 application. There's certainly some overlap of the aims. But what I actually found going through the R25 process is that no one is, kind of holding a knife to you, so to speak, and expecting you to deliver exactly on what you wrote about in the initial grant. Certainly, they want to see that there's some relation to it and that you are, accomplishing appropriate research. But the message that I took away from the R25 conference is they are much, much, much more interested in your development as a neurosurgeon scientist as opposed to, exactly things that you put on paper before you even joined a lab. And that carries forward, into the UE5 program as well. And ultimately, what they want to see is that you are putting the pieces in place to develop an independent research program. And each thing kind of builds on itself. And, at the end of it, you can kind of give a talk where you talk about how everything kind of built from one step to another. But the reality of it can often be quite messy. And the thing that I would take away is focus much more on actually developing your skills as a scientist, generating hypotheses, collecting the data, analyzing the data, then holding yourselves to exactly, the things that you put on paper initially.
Yeah, I think that's well said and wise. And the sooner people kind of learn that, the better. I think for sure the UE5 leadership at the NIH really looks at this as a training grant. And a training grant is, it's the science is part of it, and you need to have goals that will further your overall research arc. But it's the training part that matters, which is how to do the science, maybe some specific analytical or experimental skills that you're going to plan to learn. Those are the things that matter more. And obviously things change in any research as you move along. So I think that was well said. Thank you for that.
Thank you very much, everybody. I really appreciate the opportunity to talk to you all and the opportunity to be here with you.
Ooh,
Thanks, Gabe. Great talk, everybody. Have a wonderful, wonderful week.